Hey, 1, 2.
Oh yeah, thanks a lot, Rob.
No, she was not getting ready. Not yet. Her family, his No, he works here.
Good afternoon. Today is our last public health dialogues for fall 2015. And so I want to call your attention to the little flyers that we put out at your seat. And this is our preview. You get a sneak preview of spring 2016. And so we have a theme that we're going to use in 2016, which is food and politics. And so we've lined up a pretty good number of speakers for that theme. One of them, the last one in April, is a book author, and she will be speaking about her experiences as she traveled across the United States looking at low-income workers in the food industry. So that's our speaker in April. And then for January 22nd, when we kick off 2016, we're bringing in folks from WVU and across the state to talk about the farm to table movement. So I think that you'll enjoy our series in spring of 2016. But be sure to go online. We have the full schedule posted on our website. You can sign up for January 22nd, and then we'll have our full schedule printed in the next 2 weeks. So I hope you're excited about that. I am. I have to do my dreaded fill out the evaluation request. So you have an evaluation. You have pre and post questions. And then I'll make my little appeal. This is important to the training center. We have to report numbers, so I'm appealing to you to fill out the evaluation. We really need these. And we don't keep permanent data. We won't say anything if you flunked the pre and post test. We just need that information from you. Okay, I'm going to go ahead and introduce Dr. Dunn. And I was really happy to see him. And I had forgotten that we had seen each other like several times over the last 15 years or something like that. So I first met him in Houston, then in Kentucky, and now he just keeps following me around. Now he's here in West Virginia. But I think you'll enjoy this presentation. And I was looking for something different to say about our speakers other than what you have read online or in the bio. And so 2 unknown pieces of information, I think. One is that his PhD is in geography, and he actually did a postdoc in epidemiology. And the other piece of information that I think is really most interesting is that Dr. Dunn has a totally hidden life where he works very closely in the community with government leaders and other stakeholders in his, I call it a county, but you probably call it the province or at the county level. And he's organized some wonderful kinds of organizations that bring together stakeholders, community leaders, private industry, and the government to think about these social and economic determinants of health. And they've been meeting and coming to an understanding about how to solve these wicked kinds of problems that lay outside of the traditional healthcare and public health arena. And so maybe somebody will ask him about that when he's done, but he has wonderful stories to tell about that experience. So I'm going to bring up Dr. Dunn. Thank you very much.
Well, thanks for that introduction, Laurie. And every time I followed you, it was because you invited me. So, just teasing you. So thank you very much. Appreciate you being here, and hope that the reward will be more than just the free lunch for your attendance today. At any rate, so today I want to talk about some work that I've been I guess chipping away at over the last few years. It was a big part of my research program several years ago, and has been, I guess, less intense lately, but not because the issue is any less important around income inequality. And so I guess my inspiration for this, and many of you in the audience will think, oh, he's a real old fogey because he's going to talk about research that started in the 90s. So my experience with this work comes from research that did start in the early 90s. So an interest in the relationship between income inequality and health actually started about a decade before the Occupy movement and before income inequality as kind of a global issue, and certainly an issue in my country and yours too, really came to the kind of public forefront. And so in a way, it's become relevant all over again. So why don't I just dive right into it, and we'll go from there. So in an editorial in the British Medical Journal in 1996 called the idea that income distribution and health were related and that this was an important determinant of population health, a so-called big idea. And this followed from a very influential paper that a fellow named Richard Wilkinson published in 1992 in the BMJ, which showed that median income for countries was not actually very strongly associated with health in the affluent countries of the world, but that income inequality was strongly associated with population health. Now, of course, in the spirit of academic debate, others dismissed it as unsupported by evidence. I think that there actually is a fair bit of evidence to do this, but an editorial, as I say, in 92 called it a big idea. So this has been an intellectual stimulus for a body of work. Wilkinson went into retirement actually, and then became even more famous than he had been when he was working, and he wrote a very influential book called The Spirit Level, where he shows the relationship between income inequality and a whole host of social problems, including health and crime and early child development and so forth. And I think arguably in the same vein, the work of Thomas Piketty and Joseph Stiglitz are, I guess, indicators of this new interest in income inequality in the Occupy movement and all of the concern about the 1%. And actually the really big concern should be the kind of 0.01%, because that's where all the income gains have really gone in the last couple of decades. Okay, so from a health perspective, this idea of income distribution and population health is a little bit different than the things that we often think about in traditional risk factor epidemiologies, right? In traditional risk factor epidemiology, we often think about the attributes of individuals and how the attributes of individuals affect their health. This talk I'm going to give today is really much more of a population-based and operating at a different level. This is from a very famous paper in 1984 by a guy named Geoffrey Rose, who was an epidemiologist in the UK. And this paper was called Sick Individuals and Sick Populations. And the thing that's important about this particular graph, which is simply a frequency distribution of systolic blood pressure in two different groups, a group of Kenyan nomads and a group of London civil servants. And the very important point that Rose makes in this paper is that in traditional risk factor epidemiology that's focused on individuals, we might ask the question, what distinguishes this person on the distribution of London civil servants from this person? And in the case of systolic blood pressure, the answer might be high-fat diet, for example. And we would then ask the same question of the London civil servants. What distinguishes this person from this person in the distribution of systolic blood pressure amongst Kenyan nomads? And the truth is, we actually might get the same answer, because there are some Kenyan nomads that have very high-fat diets. But the important thing is that in asking that question, we'd be ignoring the fact that the frequency distribution of systolic blood pressure is significantly further to the right amongst the London civil servants than it is amongst the Kenyan nomads. And that, in fact, hypertension, the 140 cutoff, is rare amongst Kenyan nomads and common amongst London civil servants. But more importantly, in that we wouldn't be looking at the position of these two distributions. And what he tried to imply was that there may be something to which London civil servants are uniformly exposed that Kenyan nomads are not, that's far more influential on their health than the differences between individuals. In other words, the only things that we can detect that are important for our health are things that are heterogeneous between individuals in traditional individual-based epidemiology. And we ignore the social factors, if you like, the things to which whole populations are uniformly exposed. And that this to him was a significant whole. So I sort of think about the work on income inequality as an example of Rowe's going forward. But anyways, I wanted to draw a comparison first between the idea of population health in Rowe's notion and the idea of social facts, which actually come from sociology. So in the late 20th century epidemiology, Jeffrey Rose, if we kind of mash up him with the famous sociology Emile Durkheim, who wrote a very influential book called Suicide, they actually were making pretty much the same point. And the point was the same one that I just mentioned you from Rose. And so Durkheim talks about it a little more, a little more richly in saying that social facts are actually distinct from individual facts. So he says society is not a mere sum of individuals. Rather, the system formed by their association represents a specific reality which has its own characteristics. Ways of acting, thinking, and feeling that present the noteworthy property of existing outside the individual consciousness. That's good because sleep is a distinct possibility going forward. I don't want to have any extra, you got food, I don't have any extra stimuli for sleep. So this is the notion of Durkheim's social facts, and for me this is a direct parallel to Rose's notion. Indeed, social facts are an epiphenomena of relations between individuals in the society, phenomena that reside neither in the characteristics nor in the aggregate characteristics of populations, but in their social relations, how they are structured together, right? So how our society is structured. In epidemiologic terms, social facts are phenomena which all members of a population are uniformly exposed, and therefore the social environment includes the individuals that constitute it, but it's not reducible to those individuals. Okay, so my interest in health inequality goes back 20 plus years, and it comes from seeing graphs like this, which in this case shows income group by self-assessed ill health and something called the Health Utility Index, and it basically shows that the greater your income, the poorer your health. And of course, many of you will be familiar with this relationship, and I could substitute almost any other measure of social rank, if you like, so income groups, educational attainment, your position in a job hierarchy, and show the exact same relationship. And in terms of health outcomes, it's pretty much everything that kills us and makes us sick that shows this relationship. So everything from injuries, accidents, suicides, poisonings, most cancers, heart disease, mental health, infectious disease, etc., all shows a graded relationship. And of course, it's a graded relationship, so it means that there are differences not only between poor people and everybody else, but that at each step of the ladder, from the top income decile all the way down to the bottom income decile, there are these differences. So it really does implicate everybody. And this is something I think that to me, when I saw this, when I read the Black Report on Health Inequalities, a UK white paper that was published in 1980, my jaw dropped and I said, wait a second, everything I'd ever heard about health before today was better biology equals better health, better behavior equals better health, and more health care equals more health. That ignores, of course, all the things that healthcare does to actually kill people, iatrogenesis. But anyways, so that's the common understanding, right? Is it's those three things. And I said, wait a second, this says more social justice equals better health. Boy, that's really interesting. So anyways, it's kept me going all this time. But this is an individual relationship. And so what Wilkinson did in '92 is he said, well, let's look at this at a country level. Do we see the same relationship between income and health at the level of countries? And so he plotted this out at 4 different points in the 20th century. So about 1900 on this red line, indeed, there's a very steep relationship between per capita income and life expectancy about 1900, but over time it starts to produce this kind of asymptotic relationship. And what happens is that amongst the global south, the less developed countries, there is still a steep relationship. Amongst the kind of transitional economies in 1990, there's still a very steep relationship, but much shallower than those traditional economies. But out here at this tail, and my old mentor, Clyde Hertzman, used to call this the inverted hockey stick. That's the technical term, by the way. It's a very Canadian thing to say, at any rate. But out here, what you can see is that each additional dollar of per capita income buys a very small, if any, additional increment in life expectancy. So Wilkinson became very interested in this area here, and he said, well, if greater wealth doesn't equal greater health for countries amongst, and these are all the affluent countries of the world, right? So Western Europe, Scandinavia, North America, Australia, Asia, that sort of thing. If greater wealth doesn't equal greater health amongst these countries, maybe it's income distribution that is associated with health, or the degree of inequality. So then he published that paper that I mentioned earlier in 1992, and he used a measure of income inequality, which is the percentage of income received by the lowest 70% of the population. And basically the way this is done is they take an entire population, rank them by income, add up the aggregate incomes of the bottom 70% and take that as a proportion of total income. And the greater it is, so out here at 50% with Sweden and Norway, that means 50% of total income is received by the lowest 70%, and then over here West Germany. So this data comes from the Luxembourg income study, and it basically shows that the more egalitarian, the places that have a more equal distribution of income, like Sweden and Norway, have greater life expectancy than places like West Germany and the United States. Now it turns out, no fault of Wilkinson's, the West German number was wrong. It was an error in the Luxembourg income study, but it didn't actually change the overall relationship. Some colleagues of mine in Canada, partnering up with some folks in the U.S. at the University of Michigan at the time, George Kaplan and John Lynch in particular, did this U.S. comparative study. So George and John had done this paper where they looked at U.S. states and U.S. metropolitan areas and showed a very similar relationship. And I was working with people at Statistics Canada, which is our Census Bureau, and they had, they live in the cookie jar of data, and so they could basically take all of the micro data that they had access to and emulate the same analysis that George and John did. So we did a couple of papers looking at the relationship between income inequality and population health, comparing U.S. states and Canadian provinces. So provinces are equivalent to states for us. We've got 10 of them, and 3 things that are called territories, which have a slightly different, and they're up in the north, very sparsely populated areas up in the north. But we're just going to focus on the provinces, the 10 of them. And then US and Canadian metropolitan areas, and we looked at metropolitan areas that were over 50,000 population. So in the US there are 282 of those, and in Canada there are 53 of those. You'll see that in a second. And we use an income inequality, it's called the median share of income, and it's essentially the percentage of total income held by the least well-off half of the population. So very similar to the Wilkinson measure, but we use the median as the cutoff. And our health measure was age-adjusted mortality rate for the working age population, so arguably a premature mortality rate. So what I want to show you is that result, and then we'll get into some of the stuff about unpacking what's going on with US states. So this is the US states and Canadian provinces. US states are in the blue and the Canadian provinces are in the red. And what it shows is that as income inequality, where income inequality is high, like in Louisiana, mortality rates are high as well. And where income inequality is low, like New Hampshire, mortality rates are low. And it's a pretty tight fit around that regression line. And then we did the same thing for the Canadian provinces in the red. And this line is dotted because basically the slope of that line is not statistically significantly different from 0. And you can almost imagine it going in the opposite direction. Now it is only 10 points. So, there might be some statistical problems with that. So we wanted to do it for the cities. So we did the same thing for the cities. So this is the US cities that I described, the 282 with populations over 50,000, and we see the very same relationship. And then in Canada, we essentially see a regression line that's fitted, and it's dead flat. And we were crestfallen about this. We were like, what? Oh no. well, how is this possible? Because the social gradient in health exists in all of the affluent countries of the world, and yet we were unable to show this relationship between income inequality and health in Canada. But it actually became a really interesting problem to say, like, well, what's different? There are a lot of similarities between Canada and the US, right? We occupy the same chunk of rock on the globe and a whole bunch of other similarities. That's probably the simplest one if I need to. Probably don't need to point that out. So that became actually an interesting problem to figure out why those differences. I should just hasten to mention that one of the criticisms we had of the paper was that maybe it's possible, because there's so little spread amongst the income inequality amongst the Canadian cities, maybe we're just statistically unable to show a relationship. So that was easy to deal with, because and what we did is we just chopped off all the cities, the US cities that were more unequal than the most unequal Canadian cities. So we just looked at all the ones essentially right of this line. And so this is the same points in Canada and the 95 cities that are in the same range as the Canadian cities. And you can see actually the range is even narrower than in the Canadian cities, and we still were able to show a statistically significant relationship. I'll just add, this is a bit of a tangent. We managed to team up with a couple of different teams, one in Sweden, one in Australia, and one in the UK, to reproduce the same analysis for those three countries, and it produces some interesting results. This is Sweden here is in the yellow dots, and Australia is in the green dots. They're a little bit hard to see, but essentially they show the same pattern as the Canadian points. They're all clustered in the same area, and they also, if we were to fit a regression line for the Australian cities and the Swedish cities, we'd see that that was dead flat. Now the interesting thing is that the UK, while the most unequal place in the UK is still, there are many more places that are still much more unequal in the US, there is a very steep linear trend amongst cities in the UK, and which is interesting because there are some important differences. They have universal health insurance, they have a pretty strong welfare state and so forth. But I kind of liken it to issues around social mobility. That there are issues around social mobility in the UK that have yet to be overcome, right? Around the kind of embeddedness of class and so forth. Anyways, so. One of the hypotheses that was suggested to explain why income inequality might be related to health is because places with high income inequality might underinvest in human capital. And so there's some evidence of this in the Canada-U.S. comparison, but within the U.S. we can actually quantify this because you folks have this fantastic piece of data called the U.S. Census of Government. And it's really a treat to work with that because it's got all of this great data on spending by governments, and so that's what I've been working with. So our two objectives in this were to investigate state and local government expenditures and its relationship to all-cause standardized mortality rates, and then expenditures on public services, whether the relationship between income inequality and mortality was actually attenuated by expenditures on public goods. So basically our idea is that if indeed income inequality is about underinvestment in human capital, then the relationship between that spending on public goods, on public services, might actually attenuate that relationship. So a couple of key theoretical concepts we have to look at first, though. This is based on the idea that people's incomes are actually a lot more than just the cash in their pockets. So essentially, if we think about the notion of real income or effective income from economics, it says that the thing that really is important in a person's life is not only the cash in their pocket, but that plus all the other command that they have over resources through entitlements to services, clean air, safe streets, all those kinds of things. You could attach an economic value to those things, and that your entitlements to all those things, plus the cash you have in your pocket, really is the resources that you have available to you, and that actually is probably a more fulsome way, because those things are different across different countries, right? People's entitlements to services, and in fact, the cash in your pocket is a much more important determinant of your life chances and your health chances in some countries than others. And arguably, I would say that in the U.S. compared to Canada, indeed, the cash in your pocket is a stronger determinant of your life chances and your health chances than it is in Canada, just because in Canada there's so many things we just get, right? I mean, I know you guys have the Affordable Care Act now, and that's great. I'm excited about that. But we've always had universal health insurance for everybody. We've got smaller differences between school quality and a whole host of other things, more affordable college tuition, that kind of stuff. But essentially, the idea of real income is the idea of it's all receipts which increase an individual's command over the use of the society's scarce resources. So essentially, it's the hypothetical value of the command over resources an individual has, and it includes both cash income and non-cash benefits. And these can differ from place to place depending on the bundle of public goods available. And so the idea of public goods is another important thing here. And these are typically positive externalities, there are typically positive externalities associated with the provision of public goods. I won't go into too much detail about what a public good, the definition of a public good is, but the classic example of a public good actually is military defense, oddly, because it's impossible for anybody to opt out of it. But you could say that there are lots of imperfect public goods that affect people's health in a positive way, like clean air, safe streets, public schools, that kind of stuff. Most public goods services are in fact impure public goods, but they still contribute to people's effective incomes, right? Because they're resources that people have available to them. Okay, so what did we do? We looked at public expenditure data for 87 and 99. Working on trying to update this. We got the data from this Advisory Commission on Intergovernmental Relations, which drew on the U.S. Census Bureau, but they did an added thing that I'm going to talk about in a second. We used the Gini coefficient for a measure of income inequality and this is for the 48 contiguous states, and then median household income from the CPS, adjusted for state differences in the cost of living, and then we got all-cause mortality rates from the CDC Wonder Site. There's a problem though. The problem is this, that $1 spent in state A may actually produce a different level of hypothetical public services than $1 spent in state B. And this is because of a whole host of things that the public finance people call workload factors, the chief of which is actually the wage rates in each of those states, because the wage rates are the most important determinant of the workload, if you like, available, but it also can be the population composition and a whole bunch of other stuff, climate patterns, so like places that have to provide snow removal, for example, and those who don't, et cetera. Those things all make a difference. So ultimately we need to adjust for the expenditure data for workload factors. And this produces an index of public services, and essentially it asks the question, or it helps us adjust for how much it would cost a government in a state to provide the national average of services. And now there is a strong correlation between this index of public services, so the adjusted spending, if you like, and total expenditures, but nevertheless it does seem to have a bit of an influence. So just to give you an idea for this, I'll walk through education. This is one where there's quite a lot of workload factors. So there are things that have to be adjusted for, like the elementary school age share of the population, right? That obviously, if that differs between different states, then that's going to have an influence on what it costs to deliver the same level, hypothetical level of educational services. Secondary school age, children in poverty, that'll be another factor, index of wage levels, and then essentially, I won't go into the details, but we used this recommended from this intergovernmental panel, advisory panel, we used what they recommended for the weighting of all this. So what we showed is key correlations here. If we look at income inequality, and it's related to all age mortality, 0.505 is the Pearson correlation coefficient. Both male and female mortality as well, and then it's also related to the median state income. And then expenditures per capita is negatively related to the mortality measures, and the index of public services is also negatively related to those measures as well. And then we singled out education expenditures for reasons that you're going to see in a second, but they were particularly strongly related to working age mortality, and particular male working age mortality. And in fact, what we found was that we did it higher education actually, and elementary, secondary expenditures were, this is 99. But so similar kinds of patterns existed in 99 for higher education, elementary and secondary education. One of the things that we found for the spending on education is that spending on higher education by states was really strongly related, and that a hypothetical increase of of 10%, an increase of 10% on spending in higher education would translate into a hypothetical decrease of 65.6 deaths per 100,000. And the really interesting thing about that is that's, if we compare that, that would be getting rid of all the deaths from external injuries, including homicide, as well as diabetes. So essentially, it's a huge magnitude and 10% is not a small amount. Like 10% is a fair bit, but it's not insurmountable either. Okay, so we found similar results in 1999 for all of these measures. What was interesting is higher education wasn't quite as influential in 99 as it was in 1987, and in fact, what we found was that this is back to 87, we found that it was it was environment and housing that was particularly influential. So if we look at some of these, primary and secondary education is very influential. Higher education, as I said, was very influential. This is the marker I mentioned a second ago, 65.6 deaths per 100,000 in male mortality for each additional 10% in spending. Public welfare definitely reduces mortality. Spending on health and hospitals is positively related to mortality. It's not that it's causal, right? It actually could be the other direction, right? Highways, oddly, are protective, but that's probably just a general marker for the wealth of a state anyways, because we all know how our politicians love their highways, right? There's no protest group against highways, or very few anyways. Police and corrections are positively related. Environment and housing is protective, actually pretty strongly protective. Interest on general debt is just a general marker of spending, and then same thing with general government administration. I don't think those have any particular influence. But if we look then at 99, we see similar kinds of things. Health and hospitals are particularly influential. Again, as I said, higher education not nearly as strong in 99 than it was in 87, but environment and housing for both both sexes and then males in particular, spending on environment and housing was particularly influential. So what does this all mean? Well, and then this is controlling for median income and the services. So let me just skip to what this all means because I'm showing you too many tables. So if we look at just the 1987, total public expenditures are strongly related to mortality in the US in 1987, and there's particularly strong relationships for education expenditures. And the way I explain this, or the way I think about this, is that if a state is spending a lot on higher education, then they're essentially creating more options for people to have life trajectories that keep them out of harm's way, right? Because what are the things that this has a particularly strong influence on men. So what are the things that keep men out of harm's way in early adulthood, right? What are the things that kill people in early adulthood? External injuries, so violence, car accidents, recreational accidents of various kinds. Those are the kind, and having a life trajectory that puts someone in higher education is going to take them away from those kinds of harms, is essentially my argument. And so that makes a lot of sense to me. Expenditures on health and hospitals were pretty much unrelated to mortality even after adjustment. And this ecological relationship between income inequality and mortality is robust to control for median state income. So even controlling for the wealth of a state, income inequality has an influence. And the question that we were trying to ask is if spending on public services attenuates the relationship between income inequality and health. And the answer is that it does, but only a little bit. So it doesn't mean that income inequality is no longer important. It is still important, but certainly spending on public services does seem to replace some of the effect, if you like, of income inequality. So it really suggests that we need to pay attention to income inequality, but also that spending on public services can be very influential on health. Particularly, as I said before, spending on higher education seems to be influential, and also environment and housing, particularly in 99. Now, if we look at a comparison between 87 and 99, what we found was that overall similar results especially for total public expenditures. And the relationship between income inequality and mortality was, again, robust to control for median income, so that didn't go away. And again, attenuated only slightly by this public services index. Almost all the models explain more variance in 1999. These are models were explaining very high levels of variance. The main differences were in expenditure categories. The effect of higher education spending on mortality was significantly reduced from 87 to 99 for reasons I don't fully understand. There was a much larger effect of spending on environment and housing in 99 rather than 87. Now, environment and housing is a bit of a grab bag category, and that might explain it because it's a whole bunch of different things. So this one, as great as the U.S. Census of Government is, the categories are a little bit, can be a little bit wonky. Expenditures on health and hospitals and highways were positively associated with mortality after we adjusted for the workload. So which in the case of highways is just road miles. Okay, so why so different from 87 to 99? I think overall what it suggests is that public spending is a good thing for health. One possibility for this discrepancy between 87 and 99 is that the data are inaccurate in one or both years. Hard to know that. Change in the way that the data reported, also hard to know that, but no evidence that that's the case. Were there some significant changes in higher education policy and spending between 87 and 99? None that I know of, but you know, there was a recession in the early 90s, so that might have been a factor without a doubt. Categories perhaps are just too intercorrelated to be meaningful. Maybe it's just the total that matters, right? Maybe they're easily substitutable in these kind of human service ones anyways, leave aside highways and general government administration, that kind of thing. Between 87 and 99, the poor became poorer, so maybe environment and housing, so spending on housing in particular became more important to buffering the effects of increased poverty. This morning I had two different thoughts about whether to suppress the following 4 slides, and I ended up leaving them in, and I'm now second guessing myself. But I will show you why I was debating it. So I just looked at the correlation between the 87 and the 99 for this higher education, and sure enough there is a strong correlation. There's no significant outliers, but we went looking for some outliers in some of these things to see if there was anything that we could find that would explain this discrepancy. This is higher education after adjusting for these workload factors, and what it showed is that there are 3 states that ended up, not fitting the regression line very well at all, and I don't really know what was going on those states between 87 and 99, but nevertheless, that's what we showed. They are still pretty highly correlated from time 1 to time 2. And then this environment and housing measure the same thing, although North Dakota was an outlier even before we adjusted. And then this is really interesting. I've never ever seen a graph quite like this. So this is the adjusted expenditures. So after adjusting for these workload factors, the correlation between 87 and 99 on environment and housing, they're practically the same, right? So what does this mean? Well, spending on public services that increase a person's effective income or their real income may indeed be associated with population health. And I would argue, actually, they almost certainly are, right? So it's not just the cash, right? There's a lot of focus on income because it's easy to measure. But people's global command over resources, which includes these non-cash benefits, are also incredibly important for health. This is especially true for public education and welfare in 87. And then especially true for environment and housing in 99. And it's not that it's untrue for welfare and education and the other times, it's just that there seems to be a little bit of volatility over time. It appears that changes in spending in environment and housing were very well adjusted to this workload factor. That's exactly what I'm seeing here, is that the adjustment actually really makes this a very narrow and tight distribution. And maybe this explains the strong association of environment and housing spending with mortality. I'm not really sure. Such measures are not a substitute for action to reduce income inequality. So as I said, although spending on public services does appear to attenuate the relationship between income inequality and health, it's not a substitute for actually acting on income inequality. And the relationship between income inequality and mortality is really robust to this adjustment. So I hope there's still an opportunity for some discussion. I hope this was reasonably stimulating, and I fully acknowledge that there may be a thing or two that you can tell me that would help my interpretation of this data, and why I was so eager to come today, and look forward to the conversation. Thanks. Yeah.
So we're going to do Q&A, and you can raise your hand if you have a question, but if you want to write your question down and hold it up, someone will come and get your question and we'll bring it up here as well. So raise your hand or write your question on paper. And we'll be repeating your questions. We don't have mics today for the audience, so make sure you're clear and we'll repeat your question and then Dr. Dunn will answer it. So any questions?
Go ahead.
If you look at the source of public funding in relation to income, whether in terms of the funding of public goods, whether there was a difference over time in where the funds came from.
Okay, so the question is, did I look at the revenue source as opposed, in addition to the amount actually spent? No. Is that in the U.S. Census of Government? I don't remember.
Just looking at in terms of the distribution of the burden of public.
Right, yeah. So it's the question is about a distribution of the burden of public spending. I mean, we drew this from this report from the Intergovernmental Affairs Committee, and it exists essentially to look for disparities across states in their fiscal capacity, right? So essentially, different states have different levels of wealth and different levels of capacity to tax their populations and their businesses in order to fund services. And so, so we should look actually and see if indeed there is something of that. The difficulty with that is that the idea is that Intergovernmental Affairs panel advises the federal government on how to create transfers that will reduce some of those inequities. So now whether it does so effectively might be a really important point. Yeah, thank you. Yes, go ahead.
Some states have industries that are actually risky to their workers much more than other states. You can take West Virginia.
Yeah.
How do you deal with that?
Sure. So some states have industries that are more prevalent that are risky to their workers, and how do we deal with that? We didn't really deal with it, and I would say that might be the kind of thing that's coming out in the effect of spending on higher education, because many of those risky industries, the people who are at the greatest risk are the people with less skills, right? It's lower skilled jobs in West Virginia would be an example, I guess, around mining, but in other states it might be more around industry and occupational injuries from manufacturing, and so I would think that that's kind of partially reflected in that education, higher education factor for sure, because again, those are the kinds of things that cause mortality amongst young people, right? Or I didn't mention that one, but that was one of that should have been on the list. Yes, go ahead. Can I recap the London Civil Service study? Oh, okay. So, well, I mentioned the Black Report. Is that what you were referring to? Yeah, so the Black Report. Well, I mean, that's a great story about the Black Report. So it was this report. It's a great story because it was actually a white paper, which is a government white paper. So in the UK, that's a term for a government report that was commissioned by the Labour government, so the left-leaning government in the late 1970s. And essentially what it was, and it was led by a guy named Sir Douglas Black, which is why it's called the Black Report on Health Inequalities, even though it's a white paper. But Sir Douglas Black had been the head of the British Medical Association, was a very prominent physician. And anyways, the Labour government in the late 70s commissioned a panel of 4 distinguished scholars, including Sir Douglas Black, and another actually of the panelists, I've forgotten the other 2, but another one was Peter Townsend, who was a very famous sociologist who wrote some of the great works on on inequality in UK society in the 50s and 60s. And but not to be confused with the guy from The Who, the other Peter Townsend. Oh, good, there were a few people who laughed at that one. I'm getting so old now that almost nobody laughs at that anymore. So anyways, and this report was, the way I characterize it, and you could quibble with me about whether this is accurate, it was almost like a 30-year evaluation of the impact of the introduction of universal health insurance on class inequalities and mortality. So basically, after the war, the NHS was created as part of the great new welfare state in the UK, and it was one of the intentions of the introduction of universal health insurance was they thought that it would reduce class inequalities in mortality, which were very large. And 30 years later, one of the things that the Black report, or the Black Commission was supposed to address is whether indeed it had reduced those class inequalities. And the answer was no. Not only had it not reduced class inequalities in healthcare, or sorry, in mortality, they had actually increased during that time. So despite the introduction of universal health insurance and the removal of financial barriers to healthcare, class inequalities and mortality actually got worse over that period of time, which signals the fact that medicine and healthcare delivery really only deals with dealing with issues once people are already sick. And it doesn't actually do a lot, it does some, more as we move on, to determine who's healthy and who's not, right? And so then the report goes on to try and understand what are the things that could explain the widening of these class inequalities between the late 40s and the late 70s. And the answer they come up with are basically people's everyday material living conditions. That is actually what determines people's health. And to me, this was like my jaw hit the floor. I thought, this is amazing. And the really interesting thing about the report is just the politics of it. So the commission actually finished its work after Margaret Thatcher was elected. So they reported in 1980, very shortly after Margaret Thatcher was elected, and many of you will know that Margaret Thatcher would have been, not too impressed with the report that told her that class inequalities were increasing. This wouldn't have been high on her agenda. So they were obligated to release it. Nevertheless, the government was obligated to release the report. So they released it they photocopied 260 copies and they released it on the Friday before the August long weekend, the August bank holiday, in order to guarantee that it would have as the minimal amount of press exposure as possible, because they're basically trying to bury it, because they were planning to do something that was actually going to radically increase class inequalities, through the introduction of the whole neoliberal state. And there was a journalist named Nick Davidson who nevertheless got this on his desk on that Friday afternoon and went, wow, this is really important. And he proceeded to actually do a lot of work to publicize this. I can't remember what paper he wrote for, but he wrote a lot of editorials about it. And then ultimately, the Black Report was actually published as a Penguin paperback under the authorship of Nick Davidson and Peter Townsend. So, and there was, for a while, when there were still bookstores, you could actually find that, I could usually find a couple copies for a couple of bucks. And I actually stockpiled them for a while. There was a movie where it was Mel Gibson who stockpiled copies of Catcher in the Rye. I was doing the same thing with the Black Report. I'm not joking, actually. It was mainly so that people who came, invariably what would happen is somebody would come in my office and I'd tell them this story and they'd say, you need to read this report, and I'd pull it off the shelf. Here, just keep it. So I'm down to one copy now. I'm feeling better. Lori, yes, go ahead. Right. Yeah, well, that's a really good point. One of the implications of this work is, that I didn't mention, is that over time what we've seen is an erosion, and this goes to your question actually about revenue sources in some respects, an erosion of funding public services. Well, first of all, there's been a shrinkage of public services and a switch more to user fees and those sorts of things. And those are very regressive, right? So there's a difference between progressive sources of revenue and regressive sources of revenue. A progress source of revenue is something where you pay a greater amount the greater your income. So a progressive tax system, for example, means that higher income people pay a greater percentage of their income in taxes than lower income people. So for example, I don't know what the tax rates are in the US, but in Canada, the lowest tax rate is about 18% average tax rate, and the highest tax rate is about 37%. So somebody like me, I pay, my average tax rate is 37%. I have a higher income, and so I pay a greater percentage of my income. So it's actually an exponential relationship. But over time, what's happened with the whole tax cuts agenda, and we have the same thing going on that you do, which is, this thing called tax cuts disguising for public policy. That has eroded, and we are now more dealing with user fees and relying on things like sales taxes, which are regressive. Sales taxes are regressive because it doesn't matter what your income is. The sales tax on I don't know, what's a good item to think of? On a pair of shoes. The sales tax on a pair of shoes is the same whether your income is $100,000 or $10,000. So it's regressive. And what we've seen over the last 20 to 30 years is this pretty monumental shift of these revenue sources. And we need to get back to these progressive revenue sources, because what happens is that when you fund something based on ability to pay with a progressive instrument and you deliver it based on need, you end up redistributing a ton of income through non-cash benefits. And that's what happens in our healthcare system. I don't have it, it would take me a few minutes to call it up, but anyways, I've got this fantastic graph, and it's a study of the province of Manitoba, which is a province of about 1.8 million people in Canada, and it has universal health insurance. And they did, in 1994, they did this estimate by income decile of the amount that each income decile was paying into the system through taxes, and the amount that each income decile was receiving in services. And of course, the highest income people were paying a lot more and receiving very few services, because higher income people are less sick, and the lower income people were paying a lot less in because of progressive taxation, and they were receiving a lot more services because lower income people are sicker. And what that effectively does is, in a very quiet way, redistributes. And the really shocking thing about that graph is actually the calibration of the x-axis on it. So it's in hundreds of millions of dollars. So basically the amount of money that's sloshing around in the healthcare system, essentially being transferred from upper income people to lower income people through the receipt of these services based on on need, is like somewhere in the neighborhood of, in that 1 year for that one province, about $2 billion. And if we multiply that by 30 to get to the whole population of Canada, it's something in the neighborhood of $60 billion that is being redistributed through those services. And the same thing happens in the elementary and secondary school system. For us anyways, it's quite a bit more unequal in the U.S. Again, it's funded, a large portion of it is funded based on ability to pay through these progressive instruments, and it's delivered on the basis of need. And so we need, we've gone away from that, and I would say that that's something, it might be one way for those of us who are concerned about growing income inequality to try and chip away at it over time. Sorry, I'm not really answering your question, Lori, but I think it's an important point to make nevertheless. The reason I want to put that forward is that a lot of the things I'm doing with these partners, and Lori was alluding to this initiative I have in Hamilton where I work, which is actually quite a lot like Pittsburgh, right? So we had two giant steel industries, or giant steel plants. And we've gone through the exact same things that Pittsburgh has over time. And at one time there were 40,000. It's a city of about 500,000 people in the metro area. And at one time there were 40,000 people employed by the steel industry, and now it's about 2,500. And one of the steel mills actually is, it's U.S. Steel actually. U.S. Steel bought one of those companies, and they're bankrupt, and they're now actually threatening to not honor their pension obligations for a huge number of pensioners, and which is going to have a huge impact. So we have concentrated inner city poverty. We actually have differences in life expectancy between the worst neighborhood and the best neighborhood of 21 years. 21-year gap in life expectancy between the best neighborhood and the worst neighborhood, even in the presence of universal health insurance. And so what I've done is I co-lead this thing called the Hamilton Anchor Institutions Leadership. And what we did is we said we want to bring together the CEO level leaders of a bunch of the institutions and say, how could we be working together better, and how can we do big things that we couldn't do alone that might take a little bit more of a long-term perspective that would address broadly the social determinants of health. So we have the chief of police, the presidents of both the big hospital groups, the director of education for the school board, for the elementary school board, the leadership of the post-secondary education institutions, presidents of foundations. We just got the president of one of the steel companies, not the one that's doing well, not the one that's going to balk on its pension obligations. And the idea actually is to come up with these kinds of long-term things. So we've identified two priorities. One is around housing for vulnerable people, and we want to try and build more housing. But the reason we have to do that is because we don't have those progressive tax sources anymore. And in the 90s, the federal government pulled out of the social housing system altogether. So we've been underinvesting in social housing and affordable housing for a long time. So in a way, what we're doing with those institutions is a workaround in order to compensate for all of these things these massive kind of bigger structural changes that have that changed in the 90s and then 2000s. So that's the weird thing about it, is that, well, on the one hand, it seems really great. It's like we wouldn't have to do this if we actually had a progressive tax system and we actually invested in these kind of, environment and housing. It, right, comes through in this analysis as something that's really important. Anyways, sorry for the long diatribe on that, but.
All right, anybody else have a comment or a question? 1, 2, all right, let's just take those 2. And we'll go back here because we haven't heard from you, and we'll come up front. Okay.
I was just thinking about the Black Report.
Yes.
One of the problems that I have now is that I'm retired, so I watch too much television. And one of the things that really interests me are British comedies. And there seems to be a lot of indications that the health, through the National Health Program,
Yep.
that the quality, that that unless you pay top dollar, that the quality of healthcare you get is less if you're depending on the government National Health Service as opposed to those people who can afford to pay for top dollar.
Yeah.
And so I'm wondering if there's any, this concerns me because I really, really, really believe in my heart of hearts that everyone is entitled to health service. I really believe that with all my heart. But I'm wondering if there's any indication that sometimes those people who have less money get less quality health service.
Really good question. Fantastic question. So here's, and I totally see where you're coming from. So the NHS has gone, partly because of Thatcher, but even Blair kind of continued it. They've gone for these kind of market-based purchasing things where the NHS pays for something and these often for-profits or not-for-profits bid on providing the services. And so that, I think, has definitely undermined quality, because the thing is that when you have delivery by a corporation, there's an expectation of return on investment, right? That's not actually going into the services. So I think that's one element of it. But I'll switch it over and just think about it from a Canadian perspective, because you're hitting on an issue that I have talked about. So what I was just talking about there a minute ago with ability to pay. So everybody pays based on ability to pay, or it's funded based on ability to pay, and it's delivered on need. The key, and there's a lot of income transfers that occur as a result of that. The important thing is actually keeping the rich people in the system. So, because if the rich people get the option to opt out, or if they figure out that if they opted out or if they put political pressure to opt out, then that's going to drive down the quality. So the way I actually think about the Canadian healthcare system is, because we've got the rich in, they demand a high level of quality, and everybody gets it as a result, right? And now there are differences in quality. I was just last week, actually earlier this week, I was at a talk there's this organization in Ontario called Health Quality Ontario. There are differences in quality for sure, but the differences, I would argue, are a lot smaller because the rich people are in, they demand that level of quality. And you can almost say that of any system, right? So my main area is on housing, actually housing and health. And public housing, if you look at public housing in Vienna is actually the equivalent to a state in Austria. Their public housing system participates in the same way as a lot of the private providers. They have all kinds of market renters, renters who are paying market rates with them, and they essentially just use the proceeds of that to make better quality housing for their subsidized renters. So the subsidized renters and the market renters are getting essentially the same apartments. And so I think all these systems are benefited by the fact that, we're basically creating consumers co-ops, right? So one of my colleagues at UBC, who's a health economist, said, basically the Canadian healthcare system is just a big consumers co-op. Everybody banded together and used their collective purchasing power to purchase their services from the docs. And we should have more like that. Anyways.
So there were 2 more questions down. We're going to take those 2 and then we're going to close it out. So on the right and then on the left.
Yes.
Quick. When I grew up, there was public housing in Britain that started after World War II. It was good quality. And then I think Margaret Thatcher's era, they started selling it. Does this buy into your idea that housing would lead to a more health problems?
Yeah, so the question is, you know, at one time in the UK, there was a lot of public housing, and then Margaret Thatcher sold it off. So basically, before Thatcher, and how does that relate to health? I guess is a good question, is a good summary of the question. So prior to Margaret Thatcher, about 33% of households got their housing from the public sector in the UK, which is frankly internationally a pretty large number. And then after Thatcher, it was still 22%. So there was but nevertheless, there was this huge sell-off. And I think the problem with housing is that it's generally you know, in North America, both Canada and the U.S. are similar in this respect. We have a public policy that says we want to encourage home ownership. And, but there's a real inequality in the way we do that. So we have all these tax breaks, and you know, you guys have the capital gains exemption on your primary residence, but the other thing is the deductibility of your mortgage interest on primary residence. That is incredibly expensive, right? So essentially, for the government, that is foregone revenue of ridiculous sums of money. In Canada, we don't have that, but we've got the capital gains exemption, and there's actually about 7 different tax breaks that home owners get that renters don't. And in Canada, we had an okay housing policy until about 1992 on international standards, and then it got a lot worse. In 1992, the value of the 2 biggest tax breaks for homeowners was 6 times the value of all spending on social housing by the federal and provincial governments combined. So the fact of the matter is, if you want to find subsidized housing, go to the really leafy areas of town, and that's where you're going to find it, right? It's the 5,000 square foot mansions that have the biggest tax subsidies, but the thing is, they're just not recorded anywhere, right? Because they're essentially tax exemptions and breaks that don't ever get calculated. And so, you know, to me, it's a case of market failure, and it's an unacknowledged case of market failure. And basically, we've got a very individualistic attitude about it, which is your housing, your problem. It's not a collective problem, it's an individual problem. And I think that's morally wrong, but also really inefficient, right? I mean, look at the people who are very marginal with severe mental illness and so forth. It's already been demonstrated that if you give people supported housing, and almost anybody can maintain housing if they're supported, it saves tons of money in other sectors, police, emergency services, hospitals, et cetera, et cetera. So anyways, I could talk for hours about that one. I'm sorry. We have to go and you're going to direct me to the last question.
Last question.
Okay.
Your talk was very suitable for this audience, but you have to take a back version of it.
I do indeed. Yeah, I've got a version of the 87 part of this analysis. And so I'm happy to circulate some things to Lori, and she can pass it on. Oh yeah, absolutely. Well, I'll send the PDFs. Yeah, happy to do so. Thanks very much for your interest. I appreciate the conversation.
Thank you very much. Turn in those evaluations, and we'll see you guys in January 2016.